Alrighty, I am now pleased to introduce Taylor Thaxton to ground us in the topic we will discuss, and she will also moderate our panel today. Taylor Thaxton is a fourth-year medical student in the Drew UCLA Medical Education Program. She'll become a resident at UCSF Benoist Children's Hospital, Oakland this summer. Taylor holds an MPH from UC Berkeley School of Public Health, and she has worked with the UCLA Pritzker Center for 3 years with a focus on responding to adverse childhood experiences in vulnerable population. Taylor, you can go ahead.
So just to get us started, I wanted to touch on the larger context of domestic violence in the context of a healthcare setting. As healthcare providers, we are uniquely positioned to intervene in cases of domestic violence. While survivors might be reluctant to seek help from law enforcement or social services, the majority of patients support domestic violence interventions by providers across healthcare settings, including parents in the pediatric environment. So the clinical setting is really unique in that it's a place where we're used to having taboo or difficult conversations. It's a place where there should be safety and respect held between providers and patients to have, as I mentioned, difficult conversations that might not be seen as appropriate just in our day-to-day. It also offers privacy for patients who might not be used to having such a luxury, quote unquote. It's an opportunity to act in the absence of their abuser and, again, seek help in a place that should be safe and should have providers who are trained to address domestic violence or intimate partner violence. So domestic violence, including emotional abuse, is consistently linked to both acute and chronic health conditions. These outcomes can be classified based both on time course as well as degree of separation from the violence. So thinking about the survivors, one study found that the majority of patients experiencing chronic symptoms who report a history of domestic violence, the abuse actually occurred at least 5 years or longer in their past before seeking help for their chief complaint, indicating that the health effects are long-lasting. And then, of course, when we're thinking about the indirect health or the indirect impact that domestic violence has on the health of children, as an adverse childhood experience or ACE, witnessing violence in the home not only poses an immediate threat to the safety of any children, but also has a lasting impact on their health across the lifespan as a result of chronic activation of their body's stress response, which leads to morbidity and mortality over time. So when I first started working with the Pritzker Center, I came across this quote, and it really highlighted to me the seriousness of this topic and also made it clear that domestic violence is something that's within the scope of all of our practices, and we should see it as such. Survivors of domestic violence frequently use medical services. However, the prevalence of intimate partner violence is not reflected in medical documentation. And this underreporting is likely due to a variety of reasons. Some of the most commonly cited are a lack of knowledge or training, an absence of formal screening guidelines or institutional support, and overall a fear on the part of the provider of stepping into a situation where they don't feel that they have the resources or expertise to navigate and be a really challenging set of circumstances. And these interactions are further complicated by our roles as mandated reporters. I think it is more than reasonable to assume that if a provider feels uncomfortable broaching this topic, it can be much more challenging for the families who are actually living in these issues to trust that we are able to provide a safe space for them to disclose what they are dealing with. But reflecting on my own medical training, there's not been a significant amount of time spent on how to support patients experiencing domestic violence, especially in regards to the child welfare system or the downstream effects that come from reporting families. And we can all understand how that can weigh on their patients when they're being asked to be vulnerable around the topic of domestic violence, or how they can see that their concerns might be overlooked in these situations. So I'm very grateful for the Pritzker Center and this larger community for creating a space where we can really delve into this topic and hopefully take something away that will be helpful in all of our practices. And I'll go ahead and move on to introducing our panel. Thank you all for being here. First up, I'd like to introduce Karina, clinical social worker supervisor for all of you UCLA Medical Center, overseeing the pediatric service and Mama's Neighborhood, a prenatal program. Karina works diligently to identify social determinants of health that impact patients and families in accessing medical care. Next, we have Dr. Lisa Nicholas, who is a practicing obstetrician and gynecologist. He serves as the Vice Chair of Justice, Equity, Diversity, and Inclusion for the UCLA OB-GYN department and is committed to addressing and tackling the challenges of structural racism and equity in medicine, particularly related to women's health care. Next, we have Jackie Herrera, a survivor of domestic violence, who now serves as a parent partner at Los Angeles Dependency Lawyers. Drawing from her own experiences, she supports clients with open cases with DCFS, ensuring their journey through the dependency system is as smooth as possible. Next, Dr. Maya Zapata is the Chief of the Obstetrics Service at Ronald Reagan UCLA Medical Center. She's an Associate Professor of Obstetrics and Gynecology at the David Geffen School of Medicine at UCLA. She's been faculty at UCLA since 2014 and serves as a champion for equity and justice and reproductive health. And finally, we have Dr. Joseph Rojas, who is a board-certified pediatrician for the LA County Department of Health Services and currently serves as the medical director for the Hub Scan Clinic at Olive View UCLA Medical Center. Thank you again for being here, and we have a few questions for you and others on the panel. Feel free to chime in whenever you'd like. And if the audience has any direct questions, we'll take note and share those with you at the end. Our first question for today, our talk concerns mandatory reporting and supporting when children are involved. Would it be possible for you each to share a time that domestic violence has come up in your practice, how you handled it pertaining to mandatory reporting, and how you address safety, issues of safety for both the survivor and the children?
Thank you very much, Taylor. And I just feel very honored to be part of this very, very knowledgeable and esteemed panel to address this very important topic that we're dealing with. And I like the way we're framing this mandatory training with mandatory supporting. And that's where I think our system has really failed in regards to really being able to be supportive to families when they go through these crises that is relative to violence. I'm glad we have a lot of the critical stakeholders in the room as well, because I was looking at the people that have logged on. Because unfortunately, by virtue of our role as a mandatory reporter, it oftentimes leads to a situation of criminalization that can separate families and really help to perpetuate some of the trauma that we see. So yes, I've seen situations where, I've had been in a position to move forward with reporting. And oftentimes it's very important to have the involvement and engagement of our clinical social worker. And I see we have an excellent one here as part of the panel. I'm sure she will go ahead and expound where she is on this. But oftentimes we are placed in positions that we may not be able to be as supportive as we could be, as clinical providers. For women that are pregnant, we know that this is the most vulnerable time in their lives that they could be actually victimized by a violent activity. And if their children are witnessing these sort of things, that can always spill over into more trauma that is pervasive within that family, because we know that oftentimes children that witness these sort of things have difficulty engaging in the school systems, become withdrawn, and engage in impulsive activity that starts a spiral. So I'm going to toss that over to some of our experts here in regards to how they may be able to respond when they do witness something like this in the way that's within the context of our healthcare system.
Thank you so much, Dr. Nichols. As I was introduced, my name is Karina Oceguera. I'm a clinical social work supervisor at Olive View Medical Center here in Sylmar. I was a pediatric social worker for several years here at Olive View and recently promoted to supervisor. There's been so many situations that, we come across here in the pediatrics clinic, in the emergency room. I do have a particular situation that I had to work with a patient in the emergency room. It was a patient that had just recently immigrated to the US from the Middle East. The patient was Farsi speaking. So it was very, very challenging for her to navigate all these systems. When the patient came into the emergency room, she was not accompanied by her children. So obviously she was very distressed about this. She came in related to physical injuries from the abuser, which was one of her partner. She stated that they were residing. He was like a mechanic, and they were living on the second floor of the shop. And that's where her two kids were also staying. So I think, so many things from language barriers, recent immigration to the country, not being very familiar with what services and resources are in place. So we really had to get down to like the bare bones and kind of provide like the education. I think what was the most important was to ensure safety and transparency and kind of collaboration due to all the risk factors. In the situation, I did have to call DCFS. Um, Law enforcement was also involved because of the physical injuries that she had sustained. But I think one of the most challenging situations is the fact that her children were not here. We were trying to get her into a domestic violence shelter, and that was also a huge barrier because uh, I can't tell you enough how many times we call. They want to speak with the patient. The patient has to give her story, his or his story over and over again, only to get declined. And then we'll get a whole new set of numbers, some of which we've already contacted. So I think one thing I want to emphasize here in the acute setting, whether it's they come to a clinic appointment, their emergency room, or they're hospitalized, I think really and getting a better structure of like community support resources where we can have more of a warm handoff would be very helpful for our patients because we know exactly where they're going and what resources are going to be provided. I think just to wrap up the story, we were able to get her a domestic violence shelter out in the Long Beach area. Law enforcement was able to transport her, but I think the one thing that we don't get the full picture was what ended up happening with her kids. So
Thanks, Karina. Yeah, I work at the Hub Clinic, which is collaborative between Department of Health Services, Department of Mental Health, and Department of Public Health to serve children who are involved with the DCFS system. And that is children who are in the early investigation phase, as well as children who have open family maintenance cases or family reunification cases. And we certainly see a large volume of families affected by domestic violence, and that can include children who have been injured during a domestic violence altercation, and we are seeing them for a medical child abuse evaluation, to document those injuries. Or when there's a family maintenance, we may be seeing them with the victim parent. And, in those contexts, we're often speaking to the parent about their experiences. And, I think the thing that has really struck me so often is how long these parents have often lived with domestic violence, especially the more psychological components of domestic violence. And, trying to understand that, it is a process for people to be able to access help. And as Karina has said, that those mechanisms for accessing help are often really confusing. It's the nature of domestic violence is so much isolation that it can, be hard for them to access those. But, I also do see that, kids who are removed from a parent who's primarily the victim because of, what's termed failure to protect. And I think that what has struck me over the past 10 years of seeing so many families in that situation is just the way that it ignores the nature of domestic violence and the fact that It is a chronic condition that is very difficult for people to leave. And I think for those folks who have successfully left, it just speaks kind of to their strength and oftentimes to luck that things have lined up and they have been able to also help, to access services to leave. And too much is kind of left to luck. We are lucky that we have a member of our social work department who is assigned to the hub. And so oftentimes in those situations where we are seeing families who've experienced domestic violence, we are offering to connect them to our social worker as someone who is outside of the DCFS system. So someone who is, can help them to try to navigate that system, who is not trying to case manage in terms of, should we remove your child or not? Should your child have visits with, the abusive parent or not? That's not our social worker's role. Our social worker's role is to help connect the family to the services that they want and that they feel that they need at this time. But understandably, that's also, right, another layer that we're adding on to families. It's another person that they're talking to when they're already talking to dozens of people, especially early on in DCFS involvement. But we try to just, again, as much as we can, try to open a door for them, try to offer them, a way to access some services. There aren't enough, as Karina has said. But, I think specifically with regards to, because I know this comes up, is like whether or not to report on our end. When I am speaking with my colleagues in the Department of Pediatrics outside of the hub, and we are having those conversations, we really have to think about, what is the immediate risk to the child, if there is any, but also what is the risk if if the parent isn't able to leave at that point in time. So it is a constant sort of balancing of factors, that it is challenging, but that is also part of our role as doctors, is to look at situations that are really complex and work with team members like our social work, like our psychologists, and try to figure out, okay, speaking with this parent, what is the best path forward for them at this immediate time? And how can we help them to keep themselves and their child safe? Sometimes that does involve making a report. Other times that may mean that we're checking in with them more frequently, and making appointments for things like follow-up allergies, just so we have an opportunity to speak with that parent and have a safe space for them, and continuing to kind of check in and see how they are doing, where they are in their journey, to leave that relationship.
I would just like to add, from my OBGYN perspective, I am not usually caring directly for children. I mean, I have had scenarios. My other hat is I'm a family planning provider, so I provide abortion services as well. And so one of the ways that I interact with women in domestic violence is often at the time of a person seeking abortion care services. Often life events and domestic situations are coming to a head for many reasons. Not infrequently is a person seeking that abortion because they already have children in their household. They may already have open cases, and they are fearful or living with this ongoing domestic violence. And so I will interact with them in a scenario where I'm not necessarily doing the reporting. It's already been done. They already have cases open. I'm trying to support them through that, ensure that they're safe, that their other children are safe, and help them navigate. They may decide to continue their pregnancy or not, but that is often this moment where I will interact. In addition, in my OB care, we're screening patients, and I may have a patient that we'll discuss things that I'm trying to figure out. Is she actually being abused? Is there what can I do to help support them? I have probably a very, very high threshold for calling law enforcement, because it is so complex, as everyone else has described, and the impact on that person and on their children and the separation. My own family, my mother was in foster care for about a year with her sister because of domestic violence. It's something she talks about now that she's 70 with such intense feelings. It is not a small thing to be separated for the parent or for the child. And I would say that my first response for everything is to contact my social worker colleagues. I couldn't do my doctor job or care for women and their families without the social workers who help me to navigate, to then spend time with that family and understand, as everyone has pointed out, what's the complexity of their situation? What support do they actually need? Where are they at, so that we can help them make the next choice to keep them and their children safe without exacerbating their situation, without losing their trust, because they've told us, in OBGYN, for example, we specialize in private, very, very unique information that they trust us with, that they might not tell anyone else. And so, trying to weigh breaking their trust versus also keeping them safe. And can I do that in a way that does not break their trust, but actually gives them support and builds trust that we are here not to point a finger, to criminalize, or to separate them from their children, or worsen the case that they already have going on, that may this information might really impact the other cases that they have happening. So how can we find that balance? And I do it absolutely 100% of the time with our social workers. And that's usually the highlight, is that there's not enough of those people to spend the time with that patient and their family, so that we can help them navigate in the healthiest, best way for them, respectfully.
I want to share with the live experience side. When I came to, I did mention I have 4 children. One of my child was affected with his speech. So when all this was going on, when we had to move into a shelter, when we had to do all these changes so rapid, one of my sons just stopped talking when he would be getting asked questions. So many people were coming into our home or doctor visits. So, the way that his doctor was addressing the situation, how he would talk to him, just working together as a team to get him the right help. Even the school set him up with the speech therapist, what we can do to help him, because he was really affected by this whole situation. And I have so many questions, like, is this going to get better? When is he going to start, talking? So I was just very concerned, but luckily now he's 13 years old and he's doing great. We got the help he needed. So just working as a team was very important, kind of checking in on appointments, making sure I don't miss any of the, his appointments pretty much. And now he's doing great.
Thank you so much for sharing that. I'm glad to hear that your son's doing better now. I was hoping we could dive into a little bit about screening protocols, and if there are certain practices that you might use for survivors versus for children, and if there are any things that you would recommend or have seen work really well, other things that maybe don't work as well. Love to hear your thoughts on that.
Well, Dr. Zapata and I will talk about, some of the things that we're doing at UCLA in trying to improve our screening process as it relates to identifying women and families at risk. So I'll let her speak to that. But as a direct provider of care, there's certain cues that you brought up, Taylor, on your slide that makes us really want to delve further into the patient's history to try to see if we can be in a place of confidence and support. Oftentimes, women may be fearful to really elucidate on what actually is happening in their home because of fear of separation from families. And traditionally, that is the trajectory that has happened once we've identified that. But we realize that it is, like Dr. Rojas said, a very, very intimate balancing act, because our primary objective is to keep people safe. And if we don't allow a situation where we can have an intervention that may save a very, very tragic outcome, that's something that we don't want to miss. So maybe Dr. Zapata can talk about some of the things we're trying to do in our screening process at UCLA to be more sensitive to this awareness about not separating families and being supportive when we can recognize a problem. Maya.
I'll just clarify, when we're talking about there's sort of under this big umbrella of sort of social background and social history for a patient, screening specifically for domestic violence kind of falls under and right next to screening for substance use most commonly in pregnancy or just in general for our patients. And those have kind of come together because they're often in people's minds associated together. So if a person has a history of substance use, there's almost an automatic assumption or bias that perhaps their children or their family may have domestic violence or at a higher risk for that. And in looking at revamping our substance use screening policies and protocols for all of our different clinics, it's kind of unearthed and sort of highlighted our lack of standardized approach for screening in general for these different social histories and screening for domestic violence. So one of the things that's has been a nice side effect of trying to create a more standardized way to screen for substance use is also using a tool that actually encompasses their safety at home and some risk factors for domestic violence or abuse in the home as well. And so bringing more of a attention to screening in a standardized way where the patients feel safe, attention to how they get screened, what kind of questionnaires we're using, where does that information go, and that all patients get screened has really been a huge step forward for us. There were maybe some clinics if patients had a certain type of insurance where the patient sat one-on-one with a medical assistant who went through sort of a state mandated, very detailed screening, asking them about their home and their interactions and their relationships and any substance use. So of course that is very sensitive. It might screen for things that were concerning or that might be brought to the attention of the healthcare providers. Whereas in other clinics, if the patient had a private payer, there was really no screening. There was just a form they filled out that just wrote, do you drink? They just kind of checked off, do you drink alcohol? Are you married? And really there was no attention paid to that. And sometimes those were some of the more concerning scenarios where a patient was being abused by her husband. Their concern was in their home and the safety of their children. And so it really brought that to our attention and has kind of lifted up the whole topic of advocating for our patients, pregnant, non-pregnant, at all phases of life in our clinic in a standardized way so that we can really do better, screen everyone, and then actually have the means to support everyone. So we also uncovered that we didn't actually have a referral in the ambulatory setting for social work for our patients. So in my own clinic, if I was concerned about a patient's thing that they told me that they were maybe concerned about their husband's practices or that they had been hit or abused or that they were concerned for their children, I actually didn't have a referral to even place for social work. Only in certain clinics did we have social workers that worked with us. So that has allowed us to create a actual referral process, buy-in from social work to support us, and create a better dialogue so that we're looking to support patients. We're not looking to criminalize anyone, not looking to catch anyone, but really just supporting all of our patients, no matter what clinic they go to, no matter their insurance payer, in the best way that we can so we can do the right thing while we're trying to provide them their healthcare.
Thank you, Dr. Zapata. So as a social worker, I think, especially in the pediatric setting, I think it's important, or any setting, actually, I take that back. It's important to understand like the prevalence of trauma and adversity and the impacts of health within both our outpatient and our inpatient settings. Here in the pediatrics clinic, we do a lot of screening for the social determinants of health, one of that being the ACEs screening. As a result of those results, a lot of the patients that we work with will be referred to social work, whether it's for housing insecurity, financial stressors, food insecurity, trauma, and then domestic violence. So right then and there, whenever, a patient has any of these risk factors or has reported any of this, social work typically gets involved. Once we receive a referral, a lot of the times we will conduct a thorough psychosocial assessment to identify what is the demographic situation, what is their supports in place, who resides in the home, schooling, access to resources. We'll also conduct a safety assessment and assess for any other risk factors and really try to provide linkage to resources and support right then and there. A lot of the times it's a lot of psychoeducation as well, providing families and not giving them the sense of like blame or shame, but saying, these are the resources that are available to you. We're happy to walk you through this information. and, following up to ensure that they are linked and they are, moving forward. With our OB population, since I do supervise the Mama's Neighborhood program, which has been here within DHS for the last 10 years, our team also, even before they establish or they see a doctor, our community health workers work with our patients prior to establishing prenatal care. And they also do a very thorough psychosocial screener to assess for any concerns, who's the patient living with, what is their support system in place, whether the pregnancy was planned, unplanned. We do extensive screening for like substance use, domestic violence, things like that. So those are some of the screening protocols that we have in place.
Thank you, Karina, for sharing that, because I think that we can agree that there are certain risk factors insofar as seeing issues of violence within a community, and that has a high correlation with high poverty rates, housing insecurities, lack of job opportunities, family conflicts, all those kind of things, which I know Karina sees. But some of the protective factors are having a solid access to mental health services and other supportive services, where we know that is something that we have an opportunity to strengthen in our healthcare system. And being able to identify caring adults, family members, or friends, or faith-based communities to help connect with families that are going through crises, and just helping to build those stronger community connections. And I believe that can really make a significant impact, particularly with this one patient that you said was a recent immigrant, being able to enable a connection with people that are culturally sensitive to perhaps this family's needs would be a way to really help and assist them. So that's what we're all about, is trying to find solutions. And that's what we want to try to do.
To build off of what Karina had said, that within the pediatric realm, since the state of California started implementing the broad ACEs screening, that has really been where a lot of intimate partner violence and family violence has been identified. And I think that every system that is implementing ACEs screening, is trying to develop a system for handling that, and for trying to, make sure that we're keeping patient trust and family trust, that these, while we're trying to screen for these things, that it's not going to immediately land them, in the DCFS system or in the criminal system. And so that is a careful balance that all clinics are dealing with. I can say that for all of you, one of the ways that we kind of address these things, as well as broader concerns for child maltreatment, neglect, is that when those concerns do come up during a visit, that we have a policy that the provider and the attending reach out to the hub clinic, and then we sort of discuss the situation with them, and just try to provide a little bit more of a conversation about whether this rises to the level of a reportable concern, whether there's other resources that potentially we could connect the family to, and trying to help the provider to feel like that it's not a just report or totally forget it kind of situation, that we can kind of talk them through it, identify their concerns, identify the family's strengths, and then also definitely get our social work team involved, just because often, they are able to spend more time with the family than the providers are. But that's within all of you, that's how we've tried to help providers feel as though they're being supported, and that they can talk through a situation without feeling that just the knee-jerk response that they have to report everything.
Thank you all for sharing those thoughts. What I'm hearing is a lot of highlighting the importance of taking a collaborative approach to these issues, just based on the complexity of these dynamics and these situations. No one should feel like they are the sole person who has to find the solution and figure out how to help support these families. We do have resources that we can rely on. we touched a little bit on some of the associations with substance use and domestic violence, or some indicators of domestic violence. I wonder if there are any other examples you guys wanted to highlight of ways that intimate partner violence and domestic violence presents itself in the medical environment.
From the pediatric perspective, we often think about internalizing and externalizing behaviors in children. So when kids are suddenly, starting to have problems at school, acting out, problems with aggression, parents reporting to us at home that the child is becoming aggressive, we start to think about, are there other things going on in the child's life which maybe exposure to intimate partner violence or other stressors that are going on in the family. But that can often be a trigger for us to ask more questions, to probe a little bit deeper. Ideally, that's happening in the context of a longitudinal relationship with a provider and a family. There's much more trust that has been built over time versus, in an urgent care clinic or, with all due respect to our resident clinics, but, oftentimes you're seeing a different person every time. So, ideally those conversations are happening, with a provider that the family has built a relationship with. And so there's a little bit more trust. But, we do see that it affects children. And that sometimes is for parents, one of the, I would say, impetus for making a change in their life when they start to see how it's now also impacting their children. The other thing that I would say is that as pediatricians, we're always kind of trying to do anticipatory guidance. So just want to emphasize the importance of us talking with teenagers about healthy relationships. So when we do have that private time with teenagers, that we're talking to them about their budding relationships and how they interact with their partners, and screening for intimidation, violence in those relationships, because it does start early, unfortunately. And we want to, try to ideally intervene where they also have the support of a parent that can help them to think about healthier relationships. So I just also want to put in a plug out there that, we should be actively talking to our teenagers about these issues.
Yes, I'm glad that you brought that up, because that's very, very important in regards to identifying some of the issues that young people may be grappling with regards to gender identity and understanding issues of masculinity and what is femininity, and some of the vulnerabilities that they may experience as they are going through this process of self determination and definition. And oftentimes they may be in situations where they are actually being bullied and abused, and really are quite vulnerable to being a victim of violent encounters. Sometimes in the gynecologic practice that I have, that's the other arm, when women come to me with somewhat non-specific complaints of pelvic pain or other kind of entities, where I may do an expansive workup and evaluation, and I'm not really getting true answers, I start thinking that I may need to explore other areas where she may be victimized by sexual trauma and sexual violence, which is also part of intimate partner violence. So sometimes we have to be in a situation we can ask these questions and enable the patients to feel this trust engendered, that we can really extract the information and get them the kind of care and support that they need.
Just to add on what Dr. Rojas and Dr. Nicholas had shared, I think you talked about like our experience with healthy relationships and intergenerational, I think is what comes to mind, like what we see between our parents and our parents' parents. And sometimes we kind of mimic, that same experience. So I think, providing that education to our teens is like super important. A lot of where you have that confidential space to really explore what are some of the things that they are exposed to, what does a healthy relationship look like, so that we can kind of start working on, breaking these cycles of abuse. Um, Even talking about like what power and control looks like, that I think sometimes as patients share their story, they can kind of be like, wow, this is, you know, this cycle that continues to evolve. And, when my family starts acting nice, or I see my parents making up and things keep getting better. And then all of a sudden, they get into another fight, or, I'm in this situation where I don't feel safe anymore. I think since I was a pediatric social worker, I've had cases where like there was a lot of domestic violence going on, and in the pediatrics clinic, we see them up to 21, and it's not until they're like 18, 19 that they fully disclose, what they've experienced. And now they're, having issues of anxiety, depression, post-traumatic stress disorder because of, kind of keeping things together, and trying to make sure that their family is together and not separated.
I would echo what Karina and Dr. Nicholas had said. Specific what Karina had described in the young adults, the same as people become older adults, when there is chronic anxiety, and as Dr. Nicholas mentioned, also concern for sort of non-specific chronic pain or complaints of just like not being well in some way gynecologically. It often will raise my sort of suspicion and make me want to delve a little bit more. And often you will uncover something related to their relationship or safety, or a past trauma with that relationship that's sort of lingering, and concerns that they have where they need more support. Often in the setting of pregnancy, pregnancy, whether planned or unplanned, can often sort of amplify underlying issues that were already there. Sometimes it's because the person is looking for the pregnancy to appease that partner, in some way that might, be the solution or be the thing that is going to help whatever troubles they were having in their home. Or the opposite, it's the thing that now has brought about a lot of fear and anxiety because they feel like this child may be at risk, or they will now be in trouble for being pregnant, or that's going to upset their partner. So whenever there's, whether it's in pregnancy or not in pregnancy, some really profound anxiety around sort of their health condition will make me want to delve into that a little bit more to understand. And then I also, what Dr. Rojas had pointed out, in our practice, I do a lot of adolescent gynecologic care, and he made an excellent point that you use those instances to have anticipatory guidance. Often young people will come to the gynecologist not because they even need pap smears yet, but because there's, again, these non-specific sort of complaints, vaginal unawareness, a preoccupation with, and often when you delve into that a little bit, there is some recent trauma, whether that's with their current relationship that they're in, that might border on, was there a rape? Was there something that was not acceptable to them, and trying to navigate that with them, help them navigate that, and then help to have anticipatory guidance for future relationships, so that is not something that becomes a pattern, that they know what their worth is, they know that how they can protect their bodies. So it's on this spectrum of reproductive health and over the reproductive life cycle of women's bodies, that it might differ depending on what phase of life that they're in, but there's also lots of opportunities to help empower the patients, so that they can feel in control of their bodies.
I wanted to add to Dr. Rojas when it comes to talking to teens. For example, my kids now, I'm very concerned on, I want to break the cycle of domestic violence, right? And I make sure I take them in. I always tell them, talk to your doctor, let them know anything that you're concerned about, anxiety, anything that you're feeling, because I know they've been through trauma growing up. Overall, I feel like my kids are doing good. I've always think that I overthink, and I want to get them the right help if they need therapy, but just talking to them and making sure that they're gonna be fine as young adults. It's really big for me, because I want my family to break this cycle of domestic violence. So I think I've been focused on doing that with my children.
Thank you. That's amazing. And I think, we also have to call out the strength of survivors of domestic violence. And I know we kind of talked a little bit about, children having seen IPV and those modeling behaviors, but we also have to call out the fact that for the survivor parent, that having a parent who is showing up, who is present, who, is open to talking to their child is, one of the most important ways to build resilience in children, right? Having an adult that you can trust and you can talk to, that's huge for kids, and that helps to mitigate the trauma. And being able to have, we want all kids to be able to have conversations with their parents about relationships, right? Like, I talk to my parents about, I'm married and I still talk to my parents about my relationships because it's important to get feedback from other people, and that's good and bad things, right? About relationships and being able to help, teens and young adults see things in their relationship that, aren't so healthy and are healthy. And that having that engaged parent is huge, because otherwise they're going to get their information about relationships from social media, right? And oftentimes the types of relationships that are promoted on social media are more kind of confrontational, and that's if parents aren't talking about it, if we as healthcare providers, as social workers, other teachers, people in their lives aren't talking about healthy relationships, then they're going to only hear from those other sources. So, but I definitely want to highlight the fact that having survivor parents who are engaged with their kids and sharing those experiences is huge for helping them to develop healthy relationships later on.
I totally agree. I want to undergird that affirmation to you, Jacqueline, because perhaps that's the best example that you can give in regards to how you were able to demonstrate the courage and the resilience and just the ability to rise above a very, very difficult situation. Oftentimes may not have a happy ending like we're hearing about you today, but just being able to identify the resources that can support families that are in need is really part of our responsibility as physicians and caretakers, not just to do a report that goes through a system that sometimes is like a runaway train, and trying to get people disconnected to some of these labels and the shame and blame that's associated with reporting these situations is a very difficult maze to navigate. So, but my hat's off to you, Jacqueline, and what you've been able to do.
I am definitely very interested in teen dating violence. It's like my pet research project outside of the Picture Center. Huge proponent of very in-depth heads exams, and I was wondering if you would be able to speak to how you balance or address having honest conversations with teens, and also balancing the issue of mandatory reporting.
I think it's really important that, we kind of at the start of a conversation make full disclosure, right? So, my kind of usual shtick that I go with is, I have some things that I talk to all teenagers about. So when I'm, trying to normalize it, talk to all teenagers about. This is information that, impacts your health. And that's why it's important that, we talk about it today. The things that we talk about here are considered confidential. That means that I don't share it with anyone unless you tell me that you're hurting yourself, someone else is hurting you, or you give me permission. That includes that I'm not, otherwise I'm not going to share that information with your parents, with, the nurse outside the door, in our case in the hub, with your DCFS social worker, that this is information between you and I as patient and your doctor to make sure that you're healthy. And so I always lead with that, right? You never want to start asking questions and then have to say, oh, by the way, I actually have to tell someone about this, right? That's the worst case scenario. I think sometimes people feel as though if you give the disclaimer that then people are not going to open up, and that's not true. People, people just want to be treated, with dignity and with respect. And part of respecting people is acknowledging your limits, right? And being able to say that, there are some times where I do have to talk to people. And by and large, everyone is like, yeah, I know. I've yet to have a teen that didn't tell me like, oh yeah, I know. And still they will disclose things. But at least then, I'm not backpedaling and having to explain that, ooh, actually, maybe you thought that you were telling me something that I wouldn't have to talk to people about, but I actually do know. It's okay, I'm a little bit concerned about what you're telling me. Can we ask, I can ask some more questions. You can, try to also start thinking with them about who I'm disclosing to, how they want me to disclose it, if they want to be part of that disclosure. That's incredibly important. Just you have to lead with that.
My target audience lately has not really been adolescents, but actually young people who are undergraduates in college in regards to their knowledge base as it relates to issues of sexual violence and sexual health. And there have been surveys that have been conducted taking a look at undergraduates, trying to appreciate their understanding and knowledge as it relates to issues with regards to what constitutes a normal sexual healthy relationship, issues of consent, issues of how entanglement of utilizing drugs and the like may interfere with someone's understanding or ability to interact in a responsible way in regards to intimacy. And I'm sure we know all of these stories about people that have been in situations on college campuses with parties and utilizing drugs, and women and sometimes young men being victimized by actually being engaged or involved in sexual acts without their consent. So as part of the research project I'm involved with some other brilliant scholars, we're taking a look at how we can better educate and empower young people understanding about these issues. And one thing that we have found, peer-to-peer education has been extremely effective in regards to helping people understand the gamut of these issues and being able to communicate and being in that safe space in a room. Because those of us, I'm a mother and I've raised teenagers, and oftentimes they may not have come to me for information. They go to their friends and their peers, right, Dr. Rojas? That's been like their primary source of information. And then social media, like you said. So we're trying to identify other ways that people can get information that's going to be accurate and keep them in a safe space. And we found by trying to educate peers, educators to be that voice has been very effective. So more information to come about these things that we are looking at. We're looking specifically at UCLA undergraduate students.
Just to piggyback off of the peer network, we did have for a period of time peer navigators through the Reproductive Health Equity Project, and we did find that teens felt far more comfortable asking questions, about sex, sexuality, relationships to other teens or young adults. I should say young adults. They would be offered like, can I share that information with your provider, or can I ask so that I can get more information for you? And oftentimes the teens would say, yeah, great, and it was a good, conduit to opening those conversations between providers and teens, to have them be able to first talk to someone closer to their age, and someone also, who isn't necessarily having to wear kind of, a professional label, which we know is also can be barriers to some folks. So I would love to hear more about your project, and I definitely think that those are tools that would be served across health systems. That teens talking to other teens is just such a great intervention.
I agree 100%. That's part of why social media is widely used. It's that anecdote, and they see them as peers. They see peers, other young people who are maybe just a little older than them. And so it feels like, well, it has to be, the right thing, because it's coming from this trusted source, and they just respond better. And I'm at an age now where I am not their peer. So that is unhelpful. But being able to have resources to show them or to connect them to, and respecting those other resources, also lends a little bit of trust to that relationship, as well as the healthcare provider acknowledging that I know this might be a way for you to trust the source better, and having those sort of peer services available, I think, are really meaningful. I think some examples that are really interesting that I have noticed with adolescents, as I do care for a lot of adolescent patients, is something as simple as self-esteem with regards to their reproductive organs, vagina, vulva, again, perpetuated by social media, of what norms are, what they're supposed to look like, what they should be doing, feeding into their own sort of self-esteem of like, I must not be good enough, I might smell, it's not supposed to look like that. And then I'll hear reports, they'll come in for these complaints of something not being right. And then there'll be a piece, as I'll scratch a little further beneath the surface, of a partner telling them that they were ugly, they smelled bad. And it's those seedlings, those the beginnings of those really unhealthy relationships where they're being controlled by this partner who's getting them to do things by sort of controlling how they feel about themselves. And so I watch it in these young teenagers, and so trying to empower them about what actually is normal, what is within their control, what is not okay for their partner to be calling them or telling them, and having the resources. Then I'm just the old lady doctor. I'm not someone who that they trust in that same way, being able to connect them to the resources to hear over again that same messaging, that your body is healthy, and that someone shouldn't be able to talk to you that way or control your body in that way or control the narrative about your body, and that letting them have control over you is not a way to win their love. Like all of those layers of things that kind of get uncovered just with a gynecologic exam and the complaints that they come in for. It's all tied together, and it just, I see it as the seedling for then having some sexual abuse or intimate partner violence later on.
Absolutely. So then having them recognize and understand that those are signs and symptoms of abuse. And I would dare say that should not be only applicable to adolescents or young people, but some women who are older, you know, also are
still happening.
It is still happening. So being able to educate people to understand what those signs and symptoms are.
Thank you so much. I love this conversation so far. It's really interesting to hear how you each approach your work. In closing, I wanted to hear your thoughts on how you address the dilemma between building trust and relationships that's necessary within the healthcare environment versus balancing patient safety and mandatory reporting or supporting and accessing services. Is there ever a time where it feels like those two things are working against each other?
I think, yeah, even as you're saying it, I get like a gut reaction, you know, like when you have the patients where you feel like as a parent, they're trying to do everything in their power to already keep their children safe. And now they're having to report, you know, that they are a victim of domestic violence or there's been a history of domestic violence. I think more than anything, I try to provide a safe space for a patient to share. And if it ever has to go to the extent where DCFS does need to be involved, I've had some situations where, you know, I provide that transparency. And I've had families that actually I have them call with me so they hear exactly what I'm sharing, that they don't feel like I'm adding additional information that's untrue. And it really provides the space for the parent to share what's going on. And I feel like that may also be like a huge protective factor, right? Where family, like this parent is being protective. She or he is trying to make all the necessary steps to get this support, whether it's for financial circumstances that they can't leave their relationship or, you know, fear of safety of what happens when they leave. I mean, we all know that when a parent leaves, that's when they're most at risk. So I think just really trying to provide that space, and I feel like I've had better trust on the other end of it when it's more of a collaborative space where or rather than when they feel like, oh, this person, I shared this with them and now they had to report it, and you know, now I have DCFS involved and now I have another system telling me what to do, and I think that creates a lot more stress for the family.
That's an excellent point, Karina. I think it's very essential that we keep open lines of communication with the families from the beginning to the end. I have found that with this mandatory reporting of the drug testing when in the hospital, when patients had not even known that they were having drug testing, and they find a report, that already sets a platform for hostility and just total lack of trust. So that means we have to be very mindful in regards to keeping that open communication piece going on as a continuum, engaging the family with the knowledge and the understanding that, you know, safety of everyone involved is of our paramount concern, and that, you know, we really want to not just drop it there, but that there needs to be an incorporation of all these systems that are going to be engaged in interaction with this family moving forward. That means, you know, people in law enforcement need to be part of this conversation that we're having here in this room, as well as having other entities that are very important in communities like our faith-based community. The hospital systems is one part, but, you know, there's so many other moving parts that really have to be part of our solution. So that communication piece is key.
I feel like making us feel safe, making the children feel safe. When all this was happening to my family, they felt like if they oversaid anything, what's going to happen next? Are they going to remove us, or what's going to happen next if I say something that I'm feeling? Are they going to take me away from you? So I just feel like having, you know, making the family feel safe, that this is a safe place. Let's talk about what's going on, your feelings, instead of, okay, everything you say is going to be, they're going to say, and they're going to add stuff. So going to Karina, just making the family feel safe, it was big for me, because my kids were terrified of saying anything, because they already thought that because of them, we were going through all this, because they shared some other feelings, and now we're in this position, and I had to, you know, make sure, no, it's not your fault. This is a safe place. Let's talk about what's going on. So it's important. It was important for my family.
Yeah, I agree. I've seen so many kids kind of similar situation where they take on a lot of blame for having said something to someone, and then, you know, it's escalated to DCFS. And, you know, we have to be aware of that as providers, that even in situations where ultimately the report led to maybe a better outcome for the family, is that there's still guilt, right? There's still other consequences, that it's not always a clear positive. And, you know, that does affect, you know, your ongoing relationship with mandated reporters, about whether you feel you can just talk about other things that you know, are going on in your life. So I think we definitely have to be aware of the fact that it's, you know, children and survivors can feel a lot of distrust after being involved in this process. And to echo what Karina and Dr. Nichols said, is that just as a provider, I have just found that trying to be as transparent from the get-go is often helpful with trying to maintain that relationship and maintain that trust. And that in those circumstances where a report does have to be made, just being upfront with the family about, you know, what you're reporting and why you're reporting, and also working on like what next steps can you support them with, or how you're going to follow up with them, or for maintaining that connection over time. So that's the thing that I often communicate to trainees about, is just always be upfront about what you're doing and what your concerns are. That we shouldn't be, you know, that in general, you know, medicine has a history of making decisions for people and kind of hiding it, you know, and so we just need to be very conscious of the fact that we need to be having transparency with our patients and our families at all times.
Thank you, Dr. Rojas. I agree with you 100%. The patient population in general does not have very many positive examples or images of what support really looks like. So in general, in this setting of a bunch of people who are trying to do the right thing and reform how this system works, we all have images of how it can work really well. We've seen it, we've had experiences, or at least our limited interactions with it seemed positive, because we can never know the implications and unintended consequences of a family's and dynamic that happens afterwards. We might protect this particular patient, but they still are interacting with and connected in all these complex social ways with the family of that person who is abusing them, and the family of the friends who are now interacting with their children's lives and their lives. And so it's so complex. It's not as simple as, I remove you from this relationship, I protected you. And so we don't have a lot of examples for our patients to tell them and build trust, to say, if I do this, I feel like I need to keep you safe, it's going to really be okay, because we have all these resources. Because in reality, our resources are not enough. And we are trying to build trust by showing patients, families, that we know that we have to do better, and we know that we need to support you and not criminalize you and criminalize this person that you care about who is also abusing you. And why are they acting this way? What resources or traumas have they had? Our system doesn't address all of those things. And so the more we can actually demonstrate in real life for patients and families that this is what it would look like, of how we could support you and empower you, support your family, heal your family. Because I think we've been, rightly so, I take care of women, and we take care of children, but whoever the partner is who's abusing this family or lending to an abusive situation, what is the support for them, not just for the one parent that we are caring for and their children. It's just very complex. I don't have the answers of how we help families to see what support can look like when we are doing it better, but they need that. Otherwise, they really just will never believe us.
Thank you for those thoughts. I'm really struck by how there not only needs to be honesty about our role as mandatory reporters, but also the uncertainty that comes with making a report, I think is what you're highlighting there. I really appreciate putting things in context that way, that we are trying to help and we are trying to do what we think is best, but not necessarily knowing what the outcome will be, even though we are hopefully working towards something better right now. So those are all of my questions. We do have one question from the group for Jackie. Jackie, the question that we have for you from Tina is, could you talk about the importance of being able to keep your children with you and how we might help to improve the systems that allow for that? And if you have any thoughts on the medical perspective on that as well, I'd love to hear it.
I feel that when I went through my case, how everything happened so rapid, how my social worker acted with me was, yes, it was failure to protect because of my situation, but everybody in my team, like doctors, everybody that was working with me actually was positive towards me being protective with, for my children. Even though it was so hard for me to do that, because I had to, we went from having a home to not having a home, from not having a vehicle, from not having anything and taking everything away. I feel like it was more overwhelming for me, having to do therapy, classes, everything. It was very, very overwhelming, to the point that sometimes I'm like, oh my God, questioning if I was capable of doing certain things with it. So I feel like just having the right team. I was working with Penny Lane. So Penny Lane was awesome when it came to having all these services for me. And I don't know if that answers the question, but that's how it went for me. It was just, I think my team was very important when I had my case. I think it's your support behind you sometimes.
Thank you so much. I'm really glad that the team aspect felt really positive for you. I think that's something we can all take away from that experience.
Just really quick, just wanted to highlight what Jackie shared, because I think for me, failure to protect is like one of my biggest fears when we're having to make a DCFS report, because especially you build that relationship with the parent, and having that fear, like, as a result of this investigation, is this child going to be removed from their protective parent? In addition to all these systems, like they're having to go to children's court, family court, to see if they're going to request custody, whether they're going to apply for child support. So I think there's so many things. And a list of requirements, right, that you're given, and you haven't even really been able to process what is happening in real time because of all these demands and things that are being thrown at you. So, I mean, thank you for kind of painting that picture of what it was like for you, Jackie.
Just want to thank you all for joining us today, especially our panelists. I really, really appreciate you sharing your expertise and taking the time out of your day to help educate us all on a really important topic. Thank you again for your time. Thank you so much.